warmly welcome you to this year's Congress reporting from the San Antonio Breast Cancer Conference, short SABCS. On behalf of Mamma Mia and patients today, I welcome Professor Marc Thill from Frankfurt, who is doing this reporting with me. And Marc, do you would quickly want to introduce yourself?
Yeah, thank you, Alex. Yeah, my name is Marc Thill. I'm heading a department of gynecology and gynecological oncology in Germany, in Frankfurt at the Agaplesion Markus Hospital. We gave up obstetrics, focusing just on cancer. So therefore, it's done every year that I have to attend the San Antonio Breast Cancer Symposium. And this year it was really excited again to meet more than 10,000 people there fighting against breast cancer. Alex and me, we made our choice to decide what is worth to be reported regarding triple negative disease, and this is what we want to do right now. So this is a disclaimer, and these are my disclosures. And the abstract we decided to be valuable to be presented here is a study where Germany took place in recruiting the patients. So we recruited most of the patients, and it was a joint venture between the German Breast Group and the NSABP from the States, the GEPARDOUZE study. So the GEPARDOUZE study is relevant.
Names are always so funny, sorry.
What do you mean?
The names of the studies, I always have to laugh because I don't know who comes up with these names, but I think they're sometimes hilarious.
It started with the GEPARDOUZE study, and then GEPARDOUZE study, and then GEPARTRIO, GEPARQUATRO, GEPARQUINTO. So you have to be very good in Latin to follow up the different names, and GEPARDOUZE changed that. But yeah, so it's number 12 in the end, yeah.
Yeah, but nevertheless, that's not why we are talking today to discuss the names of the studies, but the content.
That's right, yeah. So the study was to get atezolizumab and a checkpoint inhibitor, so an immune therapy, tested in stage 2 and stage 3 triple negative breast cancer. So why is this important? Because we know from metastatic disease that it really makes sense to use an immunotherapy in triple negative disease. And then, of course, once it works in metastatic disease, then we try this in the early breast cancer situation, and then especially in neoadjuvant, because triple negative disease is recommended to be treated neoadjuvantly. We do have data at the moment, pembrolizumab. So pembrolizumab is the approved immunotherapy for a triple negative early breast cancer. Improved the pathologic complete response, the event-free survival, and last year we got data improved the overall survival significantly. So this is what we have, and atezolizumab is now the competitor that was not approved yet. So there had been done a lot of studies, but the data is inconsistent, so positive trials, negative trials. So everyone really looked forward and was excited to see this data now, and that was presented in San Antonio regarding atezolizumab. So this is the study design. More than 1,500 patients have been recruited. Atezolizumab plus chemotherapy versus chemotherapy alone, to make it very briefly. So the chemotherapy backbone is similar, like in the Keynote 522 study, and this is the study that led to the approval of pembrolizumab, as stated a couple of seconds before. Primary endpoint, event-free survival. So we have to, or you have to know that the pathologic complete response was improved significantly. And the question is always, do I get this advantage or this benefit out of the PCR improvement in survival? So is this translated in a survival benefit? So this was what we are very looking for.
Well, it's a completely different discussion if pathological complete remission, that you didn't find any active tumor cells after the operation, in what relation it is to the event-free survival.
Yeah, but of course, if you think of the tumor disappeared after chemotherapy, and then you may think that all the circulating tumor cells and all the circulating tumor DNA will disappear as well. So therefore, this has something to do with survival, but we don't see that there is a very strong connection, and therefore, when we traveled to San Antonio, we thought, so let's see what the event-free survival is all about when the pathological complete response was already improved. Patient characteristics are listed here. So we do have to know that how many patients have a high risk situation. That means how many patients have to had a positive lymph node status when compared with the Keynote 522 study with pembrolizumab. So 80% had positive lymph nodes. Here you see 40% had positive lymph nodes. So maybe and there are little differences, of course, we have to take into account when we talk about the results. So here are the results, and unfortunately, this was what we call a negative trial. So despite we had seen an approval of PCR of the pathological complete response, we haven't we don't see significant benefit for event-free survival. So the orange line, so this is the standard of care chemo group, and then the blue line is the atezolizumab group. So we don't see that there is any meaningful, substantial, and not significant survival for the endpoint for the event-free survival.
Well, at least it's a little. I always think like when you say it's not significant, but there's approval, isn't it? I mean, if we talk about people and
I
it makes a
know.
difference, huh?
I know you're right, and this is we can talk about when we see your favorite graphic, the forest plot, Alex.
Yeah.
But of course you're right. So there are tiny differences, and this is correct. So we are judging the results of a study always on a study level and never on a patient level. And there might be patients who really benefit from atezolizumab, but then we have to see what is the pooled information we have, because we have to talk to all the patients, and we are not able to figure out. So this is patient A, B, C, and there is a benefit, there's not. So this is something we cannot do. We're not able to do.
Yeah,
And
that's my forest plot.
hey, here we are again.
Yes, I don't like to read these, but that's why I'm happy that you're there to run us through. And I think the important thing, that's why we said it, as well as the line, the dotted line with number 1. And then if it's left to it, we're talking about benefits. But I still don't like I don't like the idea. But you can run us through it. Thank you.
I mean, maybe similar. So we love them, these forest plots, and we hate them because, yeah, we try to figure out in the different subgroups where is the benefit and where not. But of course, the study was never powered statistically to show benefits in these subgroups. But never mind. I mean, if I'm sitting in a tumor conference, and I will talk about my patient later on, and then of course I have to take into account, so are there any groups maybe benefiting from the experimental arm of the study more or not? And here we see that, let's see, the clinical node status positive. So we do see that everything is on the, as you said, on the left side, so beyond the dotted line, the one dotted line. And then we do see bigger tumor size, like 3 centimeters. You see this confidence interval. So this bar means that these are all patients, and all the patients benefited. Here you see that some patients didn't really benefit regarding this subgroup. So therefore, maybe in the future, so this is at the moment not more than hypothesis generating, that you may think of atezolizumab as a drug that has a benefit in a node positive disease, and in tumors with a size of more than 3 centimeters, but for the reason that we have an approved drug, pembrolizumab, so no one really would think of a not approved drug. Well, this will not lead to an approval when we have an approved drug. So secondary endpoint, overall survival, I think we don't have to talk about that, because if you don't have an event-free survival benefit, then you don't see an overall survival benefit. Regarding side effects, we know that chemotherapy plus minus an immune checkpoint inhibitor will not lead to any differences that are substantial regarding the chemo side effects, because what we see, especially by using immunotherapies, is that we have these immune-related side effects. And this is something that can happen, that can occur, usually by using pembrolizumab or atezolizumab, that we use a metastatic disease. So atezo is approved for metastatic triple-negative disease. Then we see that thyroid is really affected, but of course everything can happen. And for us as physicians, as therapists, we have to think of every side effect of every situation. It's really crazy. There's nothing that is not possible. So therefore, these are, as I said, special immune-related events. And then, of course, this only happens
long term, right? I mean, if my thyroid gland is damaged, we're talking about something I have to deal with forever, right?
Yes, definitely. Yeah.
So that's just like, if it's, say, okay, a fatigue, if it stays, that's also bad or whatever. But often these side effects disappear or can disappear. But here we are talking about something that is not just there for a little period. So I think it's much more difficult to decide then, if for the minimal benefit, is it worth it to face these very heavy side effects that are staying, right?
Yeah. Absolutely. Yeah, as you said, so if the thyroid is affected, then this will accompany the patient for the rest of the life. And there are others like an pneumonitis, for example. So this is immuno. So to make a long story short, so immunotherapy will lead to an immune reaction, and immune reaction is translated when we think of symptoms that you usually see when parts of the body are infected, so have an infection, so like brain infection or lung infection or bowel infection, all that. But this is done then as an effect by the immunotherapy, so therefore everything really can happen. And therefore you have to weight, of course, the advantage, the benefit of a drug and the side effects. And if you have a drug that has inconsistent data, you would never use that. Yes, to conclude the study, I said negative study. So atezo did not result in a statistically significant increase. Primary endpoints were not met. So therefore, for us in daily routine, nothing is changing. We use pembrolizumab as a drug that is approved, that has shown significant improvement, especially in overall survival in tumors with a size of 2 centimeters or bigger, or positive axillary lymph nodes. So this is the indication for using pembrolizumab in the early breast cancer treatment. Okay, Alex, so this was the first, and now we do see maybe something we have to discuss even more, because this is data that has something to do with surveillance, something to do with can I get or can I have an approval regarding the follow-up of our patients, not just using CT scan or bone scan or whatsoever. Maybe using some more intelligent methods like circulating tumor DNA. So this is the ZEST study. So ZEST study is a study that took into account triple negative or HER2 negative but HR positive patients with a gene alteration. So we will talk about the details. Let's talk about the details here. So this is This is anyway, this is listed here. So
Yeah.
we always prepared everything in the way that we have the first question. So for whom is this study relevant? So we do see different subgroups here. We have to talk about BRCA. So I recommend to watch our take regarding the BRCA mutation carriers and the news from San Antonio Breast Cancer Symposium. But the story is, you can read it by yourself, but the story is, can I follow up on patients smarter than before to find out, so where are the patients who have a risk of recurrence and may benefit from an earlier treatment? Because this is something our patients, they ask you, Alex, as well. I mean, they say, well, breast ultrasound, clinical examination, mammography, is this all? And then we say yes, because this is a symptom-adjusted follow-up, a symptom-adjusted surveillance we perform, and we don't use any CT scans and so on.
Yeah, I think it's a lot of it's psychological as well. You know that a friend of mine, she wanted to buy what was it? She wanted to buy an ultrasound machine that she could daily check her breast. You know, it's something that, because it's a disease that you don't feel, and that gives you a certainty, you know, to say like, okay, everything's okay and nothing has reoccurred. And I think especially after you're in a treatment cycle and you're regularly seen and your blood is checked and everybody's there around you, and then suddenly it's like, we'll see you in 3 months or in 6 months, and people go like, no way. I mean, it's like, what if something happens? So I think it's yeah, I know that there's guidelines, but I know that there's different ways of handling this depending on the patients. And if I think also it's like, if I don't feel comfortable as a patient, I should always say so and say like, okay, well, I can't handle it. You know, we need to change something.
Yeah, I totally agree on that. And this is always this is always in a way risky if patients participate in trials where you get that positive result, telling the patient, well, we do see circulating tumor DNA, and then we know that this patient has a worse prognosis regarding an earlier recurrence, and the patient says, oh my God, what to do right now? And then you say, I don't know, because we have no idea when do we really see a recurrence that can be shown and then of course you have to do that in CT scan, for example. And we don't know what to give, what kind of treatment. So what is the most appropriate treatment? And so therefore this trial tried to combine the prognostic issue and then the therapeutic issue as well. You see down here that molecular residual disease is defined. So this is these are tiny parts, as I said, DNA, genetic informations of the tumor in the blood of the patient. So this is a study design, nearly 2,000 patients, and then these patients triple negative, HER2 positive with a BRCA mutation. And the monitoring of ctDNAs, this is the main part. So it's not so important what kind of subgroups had been implemented in the trial. Of course, you if you design such a trial, then you will embed the most aggressive subtypes, maybe because these are the patients having an early appropriate have an early recurrence earlier than maybe a hormone receptor positive disease. So this is something I hope you know. So this is something your physician has to tell you, that your risk is increasing in the first 5 years and then it will drop down. And for hormone receptor positive disease, it will increase in the first 5 years, but then is on the highest level in 5 years, and then it will drop down. So hormone receptor positive, and then will drop down like over the next 5, 10, 15 years. So therefore, if you want to show any benefit from such a tool regarding tumor or disease monitoring, then of course this has to be done in the most aggressive subtypes. And then you see that ctDNA was measured, and then in all the patients having ctDNA, 1900, and then 147 patients having ctDNA, then it was tested, does it make sense to give a PARP inhibitor, so niraparib or nothing? And a PARP inhibitor, now this is inhibitor we know, so this is a kind of treatment we know from BRCA mutant carriers to influence the instability of the tumor, very, very effective. So this was the reason why this drug was chosen for the study. Again, very briefly.
That's the explanation again of the PARP inhibitor.
Yes. Yeah, you can stop the video and then you can read it. Well, okay, so patient characteristics, as we always say, we have to know what kind of patients participated in the trial. You see that triple negative disease was yeah, in nearly 90% of the patients. So we do see that most of the patients being triple negative are BRCA mutant carriers. We see positive lymph nodes in around 36 patients. PCR is listed. Yeah, BRCA status mutated 22%, not differentiating between BRCA1 and 2. Just details. But I think that the most important thing is, does this work? So the ctDNA monitoring, and we do see that we have some more characteristics of the patients where ctDNA level were found. So what is the patient group where we do see a ctDNA level later on, and most of the patients had in comparison, so when they had been treated neoadjuvant, most of the patients had a non-PCR. This makes sense. So if I have a pathologic complete response and I expect that everything is gone and destroyed by chemotherapy, then of course it makes sense that the patients with a non-PET CR, where we have residual tumor, macroscopically residual tumor, then these patients may have minimal residual disease in terms of ctDNA. So some more study, some results of the study. We do see that regarding the detection of ctDNA, because this is quite important. So when am I able to expect a ctDNA that can be detected? And this is more often quite earlier. So it means in the first or within the first 6 months after cancer treatment, and especially in the more aggressive cancers, such triple negative disease. So therefore, if we take a short conclusion in the meantime, then I would say test the triple negative and test it early, and then you will find ctDNA level. There we see the correlation between the detection of ctDNA and the occurrence of relapse, and that means yeah, the earlier you see ctDNA level, you detect the ctDNA, then you have a higher risk of relapse. And this may help, of course, maybe later on when we are doing studies like the SURVIVE study that is run in Germany at the moment, when to test. So when does it really make sense to test, and yeah, what subgroup is the subgroup I would recommend to test in triple negative disease is the subgroup I would say this really makes sense with the data we have seen here. Then we see that the relapse-free survival. So this is quite interesting right now, because once you have a ctDNA level, then you want to know as a patient, so what comes next? So is there a treatment recommendation? And in all, so many studies that have been presented before didn't really tell us, is there a distinct treatment recommendation? We always could say, well, this is a worse prognosis on one side, but I have no idea what comes next regarding the next treatment line or the next compound. And here we see that the patients are benefiting from niraparib, but the problem was that the study, I can say that the study was discontinued very early, and the numbers are very small. You see that 22 patients placebo, 18 patients in a niraparib arm. So this is very hard to take out any consequences out of such a study, and this is yeah, not good news, but maybe this is a door opener for the next study. So sometimes it takes really ages to finish a study successfully. This has something to do with our mindset, so maybe that will change our mindset. This study. Then we do see that there is not a real correlation between the ctDNA level and niraparib, same situation, so low patient numbers. So it works. The question is, where does it work better? And this is something we have to follow up in the German trial, in the SURVIVE study. And this is what I summarized on the right side. That we do see now another study, because we had seen so many other studies showing that ctDNA, since it is detected, then will lead to a worse prognosis, and we have to find out what is the proper treatment for these patients. And the SURVIVE study is at the moment underway, and you are able to, if you Google SURVIVE study, then you will find centers in Germany. And if you want, you can participate in this study, because this study does the same as sub-protocols for some compounds, but is detecting ctDNA, and then once the ctDNA is detected, then you will get an appropriate imaging, that means CT scan, for example, to find out is there any recurrence, and then earlier detected than maybe without ctDNA.
Yeah. In a way, it's not satisfying, and it is. It's something. Yes, we know more. Maybe we can also warn from quick tests or something that are not very scientifically proven, because that is, I think, that is the triggering a lot of uncertainty amongst patients. And I think, yes, this study doesn't really give you a lot of certainty what to do, but at least it is the basis maybe to continue the research, and maybe enroll in the SURVIVE study or something to have a way. So therefore we considered this a very important study, and included it in our selection.
Yeah, right. And we also included the study that you, as the audience, don't look in the internet for a ctDNA testing, and then you will occur like patients in Frankfurt. They come to my practice and they say, now I have ctDNA positive, and I say, so what was done? So what was the technique? How was ctDNA measured? So how was circulating tumor cells, for example, counted? And then you pay a lot of money without getting any beneficial information in the end. So participate in a SURVIVE study. I think this is, for the moment, the best choice. Yes, so
Yep.
talking a lot about this very, let's say, complicated but very important topic. But here we finalize the triple negative part.
Yeah, thank you very much for taking your time to running us through all the details. And you always have such a nice way of explaining things so everybody hopefully can understand it. And I look forward to our next take. Therefore, thank you, and goodbye.